Wonderful. Well, thanks, Allie. And thanks to everybody for joining me today over your lunchtime. I really appreciate this opportunity to share with you information about humanizing something in this digital day and age. I was just telling my husband the other day about my first BlackBerry because we had both just gotten our new iPhone 12s, which I guess I should have waited a couple weeks because the 13 is coming out next week. But nonetheless, I was telling him that the BlackBerry was for me where that digital connection really started. And I told him about how at the job I was in at the time that those things were becoming popular. I resisted it for so long as I could. And all my coworkers around me were getting their Blackberries and doing cool things with it. And then, one day I was in a prospect meeting and one of my colleagues sent an Excel file to the prospect during the meeting. And it just shocked me. And I was so excited and couldn't wait to get my own BlackBerry. And after that, I was hooked, and the rest they say is history. But even with this amazing BlackBerry, and of course, then the Blueberry that followed, which was really just a BlackBerry that was blue, nothing really could have prepared me for this digital world that would become that we live in today. And even beyond that, I could never have anticipated the accelerated digitalization COVID has brought our way over the last 18 months. But what many of the lessons have taught us over this past 18 months is that even with all of the efficiencies of technology, people still crave human interaction. And it's a good thing because that gives us an opportunity to build in more of that face-to-face time where it's most efficacious. And I'll apologize in advance for my clicking back and forth. I've got a lot going on here on my screen, but to start today, I think it's always helpful in presentations like this to share my context with you so that as we talk more, you'll understand the perspective from which I'm coming to this topic. So I work with a company called ClaimAid, headquartered right here in Indianapolis. And it's an interesting perspective because for over 30 years now, throughout all of the digital transformation, which of course spans from well before my BlackBerry, through every iteration of the iPhone, and then subsequently through COVID, we've been providing an environment for patients to have access to real human beings to help them to find those coverage resources that they and their families need. And at ClaimAid, our goal is to positively impact every life we touch, and putting that human element at the center of our solutions is our business model to accomplish that goal. So that's the context that I'll be talking with you from today. And with that, let's dig into the topic. So to set the stage, we're going to talk about two really basic needs that need to be filled. The first is that every day, you as healthcare facilities serving patients, you have them coming through your doors who do not have healthcare coverage of any kind, or maybe they have a couple coverage resources that they think they can use, but ultimately it may not be enough to, it may not be all that's available to them and enough to pay all of the bills that they will eventually have. And not only do some of today's patients not have coverage, it's likely if they don't, that someone in their family doesn't either. Maybe it's their spouse or a child or even a parent, or maybe they're dealing with all of the above that are not covered, especially in the rural setting where many of you today on the call find yourselves. A couple of weeks ago, I presented this topic at the Ohio Rural Health Annual Conference, and there was a speaker who went on before me who showed a slide that indicated that 73% of adults and 69% of children in vulnerable rural hospital communities, try to say that 5 times fast, vulnerable rural hospital communities were uninsured. And these people might not be coming for care today, but they are definitely part of your patient population and might be walking through your doors in the months to come. So patients need coverage, so do their families. That's the first basic need that we're going to address. And these days, we're tying a lot of things back to the pandemic as the source of so many of our problems. But lack of healthcare coverage is not a pandemic-specific issue. As I mentioned, the company I work for has been helping uninsured patients and families without coverage for over 30 years now. There's been a need for a really long time. It's not a new thing. In fact, when I was researching for putting this presentation together, many of the statistics I found were from 2019. So that's pre-pandemic. And clearly this is not a COVID-induced situation, but certainly COVID has contributed significantly to the problem, but I guess I don't have to tell you guys that because you have patients coming without coverage who can't pay their bills and have had for some time. But in all of the data that I was looking at, something that I found that was particularly interesting was that those within the uninsured population, non-elderly, so not counting those in that kind of Medicare bucket, 73% of those people were part of a family where one or more members of that family were full-time workers. So again, this brings us back to the fact that patients may come in with some insurance through an employer or elsewhere, but it's quite likely that they have family members at home who are not covered. And that is shifting all the time, especially today with some of these instabilities in the workforce and job market. Now, I don't want to pile on to the pandemic conversation because I know that we're all so inundated with it daily, but the truth is that this lack of healthcare coverage didn't necessarily get better over the last 18 months. So we do have to talk about it. And what statistics nationwide are telling us is that there's been a tremendous amount of increase in the uninsured Americans over this past year. In fact, 31 million to be exact. And much of that was attributable to the fact that over 20 million people lost their jobs, which means many lost access to employer-sponsored healthcare coverage. But what we also saw as a country is that with these jobs and healthcare coverage lost, many people were starting to enroll in Medicaid and CHIP during this time, which we know can be a very complicated process. And I know that statistics can tell us just about anything that we want to hear and certainly can convey various stories. I always laugh when I see a statistic that's tied to a sample size of 10 or 15 people, sometimes even less. It's amazing. But one study I found in preparing to talk with you today was put out by the Commonwealth Fund. Excuse me. And it was a national survey of over 5,400 adults between the ages of 19 and 64. So it was a pretty significant sample size of working age adults. And there were a lot of findings in this study, but particularly what struck me was that more than half of American adults who contracted COVID or lost a job because of the pandemic are also struggling with medical bills. Half of the uninsured respondents in that survey and 36% of those that even had insurance said they had a medical bill problem or were working to pay off medical debt. And this is really where we see why it matters to us on this call today and in this conversation, because not being able to pay medical bills definitely can have a long-lasting effect for the families that are experiencing that situation. And you see here in other statistics I have on the slide from that same Commonwealth Fund survey that many of the people who were uninsured or struggling with their medical debt used up most of their savings or even took on credit card debt to try to pay for some of those things. And others even further delayed going back to school or making a change in their career because of the medical debt. And, even more disheartening was how many people were unable to pay for basic needs because of that debt. And what this tells us is that life is complicated and people and their stories, their family stories are very complex. And these people are your patients and they're coming through your doors. They come in to see you because they have physical ailments, but they bring those financial woes with them too. And that stuff probably doesn't help in the healing process, but that's another presentation for another time. But it does, however, drive home the point that these patients need help in finding coverage, and they need that assistance that doesn't, in a way that doesn't ignore all of those complexities that are going on in their lives. And so this brings us to the second basic need, and it's really the simple fact that hospitals need revenue. And I can sort of hear a couple eyes rolling because it is very simple, right? Of course, you need revenue. But in order to provide the services and contribute to your communities, you need to get paid. And much of that is coming obviously from the payers, which in and of itself is requiring more and more attention to manage denials and resubmissions of claims. But your revenue also depends on your patient's ability to pay. For many rural and community hospitals specifically, the pandemic really hit those communities hard. And to stay independent or even work effectively as part of a larger system, you needed to capture as much revenue as humanly possible. And truthfully, pandemic driven or not, you face all kinds of constraints from legislative requirements to, changes in your patient mix. It was interesting at the Ohio Rural Health Conference I referenced earlier. There was a gentleman from Chartis, his name was Troy Brown, but he noted that the increase in reliance on outpatient services as part of the total, revenue for hospitals in Ohio was before the pandemic at about 32%, but after the pandemic, it was at 76% of total revenue from the outpatient services. So you can see those mixes of patients are changing, and that creates a new dynamic and new things for you to address as a facility trying to maximize what's happening in your revenue cycle. Things like the growth in telehealth services too. I mean, that's having an impact, good or bad. It depends probably on the day, but patients are, still struggling financially, and all of that together really creates a perfect storm and can have a negative impact on your overall revenue. And, you see here things like supplies and expenses and drug costs, all of those things are on the rise. And, according to the American Hospital Association, they're actually up 25% in total for this past year. And while things are looking better for this year, it's still predicted that the industry as a whole could see a potential loss again. So what this means is that, financial risk is existing for both the hospital and the patients. Patients are slowly paying or unable to pay. Bills are going into collections and, maybe even being written off frequently as bad debt, while you guys as hospitals are seeking solutions to keep afloat while also trying to provide that excellent patient care, which is your priority. And what we've found is that many facilities are really looking for efficiencies and cost savings wherever they can be found. And in doing so, many are turning to automate as much of the revenue cycle as possible using some of the latest technology. And, there's so much new technology and it emerges every day. Some is very high tech, these solutions that are really great when you are listening to webinars online and talking. You have a big system that comes on and tells you how they have created this amazing automated system with all kinds of things like what you see here, the data analytics and all of those artificial intelligence things, but these are not really scalable yet for smaller systems in rural facilities to be able to customize them to meet the exact needs that you have within your revenue cycle. In fact, automation is great, and it can do some really effective things to create those efficiencies with the more mundane and repetitive tasks. It enables, the employees to focus their attention and more of their skill sets on complex roles and responsibilities, which also allows the revenue cycle managers to invest in developing more specialized and skilled teams in the areas where they're needed. But avoiding these touch points, these unnecessary human touch points is good and efficient, but there's definitely a catch. And many organizations are benefiting from also a shift to more patient-facing roles in the revenue cycle because some of those require human-to-human interaction and improve the overall patient experience. Because what studies show us is that consumers, which includes your patients, overwhelmingly want to deal with human beings. And I'd argue that patients even more than the average consumer, because if you think about it, we've all experienced healthcare system personally or with a loved one when we're trying to help someone that might need some assistance. And I can just share a quick story that I experienced with a neighbor of mine a couple of years back. She was just at a really low point in her life and, was 64, lived alone and had recently been forced to retire from her job. So she lost her health insurance. She actually got a DUI in her driveway, which I don't think that's very easy to do, but she was then unable to go and take care of her disabled brother. And, in talking with her and trying to figure out what was going on with her situation, I learned that she had been off and on of medication for depression, and none of it was regular or consistent. So she started to drink to just ease her anxiety, and it had really become much more than just an anxiety fighter over some time. I called her one day and I could hear that she wasn't doing very well, and I convinced her to let me come over and take her to a facility that specialized in care, the kind that she needed. And all she could tell me was, please don't take me to one of those rehab centers. I just don't want to go. And I promised I wouldn't take her there. But when I picked her up, she hadn't showered in about a week. And she grabbed her purse, and God only knew what was in this thing. I mean, it was just overflowing with stuff. And I did take her, put her in my car, and we went off to a really nice behavioral health hospital. I had no idea how it was going to be paid for, and I knew it was going to be very expensive because they gave me a daily rate that was so outrageous I can't even repeat it. But I knew that that's where she needed to be. So once we arrived there, though, we were seated in a little room and greeted by this really nice woman who talked us through everything, because my friend was in no state to make any decisions. And she actually wouldn't be for quite some time, but that patient advocate worked with us. She handled everything, filing for Medicaid until her Medicare would be available, filling out the applications, going through all of the approval for everything, connecting her to all of the proper doctors and caseworkers and pharmacies and transportation. I mean, just everything that she needed. And she was really worried about the cost, but the advocate made it possible for her not to worry about those costs so that she could focus on getting better. And I'll never forget that woman. I can picture her face today as I sit here and tell this story. She, had she given us a number to call or a website to go to, I would probably be still trying to figure all of that out, because my friend was sick. She was physically, mentally, emotionally, financially, just in a bad way. And what she needed and what I needed as her helper, her liaison to the system, was a human being that could sit down and walk us through it. And that's what we got. And I'm glad to say today she's 2.5 years sober and taking care of everybody again. But I'll just never forget that time with that advocate and what a difference it made in that experience. So, I talked about some of the stories that we see on webinars and presentations, things, from the big publications like Becker's and HFMA, about some of the creative ways that large systems are using technology. And it reminds me of Eve. Does anybody remember Eve, that avatar from Avidyne from several years back? I remember when I first saw her and was introduced to her as an alternative to a live customer care agent. It was such a neat technology, and it really is still today. It's being used in a lot of places to bridge that gap from artificial intelligence logic to actual interaction. But as I think about people like my friend, or as you think about the patients who come into your hospital and the people that are represented in your overall communities that you serve, who do you think they'd rather talk to? One of these avatars, or a real human being who can relate to what they're going through when they're facing both financial and physical hardships? That 83% that want a human interaction probably is even going to increase to a higher rate. They just want a real person to listen to their story and to guide them to a solution. And what we know as an industry is that once a claim goes unpaid, so much of the time it remains there. Whether or not you're uninsured, which is a very high rate, but even significantly for those that have some coverage. So, streamlining and fine tuning the digital approach for the part of the revenue cycle that you can, and where it makes sense once the claim is unpaid, certainly can help to generate some revenue. But really, what if we could just increase the chances of getting these things paid from the very beginning by helping the patients and their families, and help them tackle those issues of being uninsured or underinsured from the very start? That might create really the ultimate efficiency when a claim never has to become an unpaid claim, when it's covered from the start. So creating that path to resources and ultimately to payment will drive revenue from the very beginning. Which brings us to an interesting intersection of both patient needs and limited hospital resources, which is just the perfect place to introduce that human element. It's at the place where patients can't pay and hospitals are experiencing the increasing costs of providing the care, that securing coverage for patients is most critical. And humanizing this process of identifying resources and walking the patient and families through to the point of getting coverage and then maintaining coverage over time can certainly help to ease the financial stress that patients experience so that they can focus on recovery, and also eases the stress of the hospital so that they're booking revenue and meeting their financial goals as well. I'm going to take a drink here. Allie, if you've got any questions coming in on chat, just let me know. I can't see the chat from my view, so I'm not sure if anything's come in yet.
We actually haven't had anyone submit questions yet. Just a reminder that everybody can submit questions if they would like during the presentation, but we will have time at the end as well.
Okay, excellent. Thank you. So how do we do this? Well, it really starts by just listening to patient stories, and having the right patient advocates in place to do that makes all the difference. There's a big difference between listening and listening with the intent and the skills to actually solve the problems. That starts with training. And of course, anyone in the advocate role needs to be well versed on the mechanics of Medicaid and marketplace options. And we'll talk about that a little bit more here in a few minutes. But more than being just up to speed on regulations and application nuances, it's really important that someone in a patient advocate role understands how to build relationships. How to establish the trust so their patients see the genuine empathy and compassion that they have. This kind of training, when these people are put in place and this type of eligibility enrollment process is designed, is often overlooked. Patients are living with so many different financial shortfalls that they're more likely to seek care and pay their medical bills when they have coverage. So figuring out how to do that for the patients from the beginning takes a lot of training and skill that is often overlooked in training on the mechanics of the enrollment process. So let's talk a little bit more about this. So who are these patient advocates, and what makes them the best choice for the eligibility enrollment? First of all, they're available. And I know that sounds really obvious, but they have to be available, have the right mindset, available to listen. And being able to meet people where they are is really important to making that connection, both physically, which I'll talk about in a few minutes, but in this context, we're thinking about it figuratively as well. And that goes back to the proper training. Having a experience and training to understand how to talk to someone who's going through challenging times helps to build relationships. And it's that relationship that is going to really help with the continuity of coverage for that patient and their families. A lot of times these advocates have heard similar needs in the past from other patients that they've worked with, and that allows them to really empathize with that patient they're currently working with, and demonstrate that they understand the situation by maybe even sharing examples of what they have seen work for other patients like them. That makes the patient feel like they're not alone, and they're not the only ones having gone through difficult times like the one they're experiencing. It also helps for these advocates to have a really strong awareness of the resources that are available in their community, and also how to help patients to get connected to them, which that establishes trust, that the advocate hears the needs of the patient and puts them in touch with the right resources. It's really important to just listen for cues about things like employment history, something that could indicate eligibility for additional coverage, or even information they might share about their family. Do they have a child without coverage, or can the advocate help to enroll a family member even before they need it? And these small steps, they just alleviate so much stress for the patients and help them to feel like they are in control of their situation, which when they're dealing with a medical challenge coupled with financial strain, and then trying to figure out how to get health insurance, regaining that control is critical to their recovery overall. It's really the difference between starting a conversation about who a person is versus jumping right into, you need to complete this paperwork and sign up for this program. And that's how relationships are built and that trust is established. And these are really special skills. They're not something that shows up in a Medicaid 101 training manual, but rather they're soft skills that can be learned when additional training is included beyond just the basic technical skills. It's a pretty unique combination of sure, proficiency at enrolling into coverage and completing applications, but also what we would maybe label social worker skills. Having a servant's heart and wanting to make a difference in the lives of the people that they interact with. Successful patient advocates also are just overall problem solvers. They have a skill set that allows them to identify barriers to coverage and, maybe the ability to pay and to work to remove those barriers. Here's an example of that. I'll tell you what I mean by that. Many times this whole eligibility enrollment starts with a birth certificate, right? I'm sure all of you, as you know, many people don't have birth certificates. And, right there, the process comes to just a screeching halt for anyone who doesn't have a birth certificate. And until they can get one and secure it and turn it in to Medicaid or whatever program they're applying for. And now, when someone is maybe pretty sick and has no health insurance, no money, maybe no job, they can't even do anything about it until they have a birth certificate. And trying to figure out how to do that, it's just so frustrating. Many eligibility processes, especially those that are very digital in nature, may tell them to go get the birth certificate, submit it, and then we'll go on to what's next. And maybe this birth certificate is one of 10 different pieces of paper that they don't have that they need to provide. And this is exactly where patients hang in limbo. Claims start to add up during the waiting period, I guess, when they're trying to figure out how to get their birth certificate or other pieces of paperwork. And the claims often just go unpaid, but it really doesn't have to get to this point. Think about the alternative where the patient advocate, as the patient's authorized representative, can acquire these documents for them. They can reach out, they can get a birth certificate, they can call for employment verification and income history, all of those different things that take those tasks off the plate of the patient. A lot of the people that are in advocate roles maybe even used to work for some of these agencies, so they know how to navigate through it effectively and who to call when they need to get something done. And oops, sorry about that. Technology, the better it gets, the harder it is to use. And the most efficacious eligibility enrollment process requires the ability to just simply move beyond a checklist, to go above and beyond and find solutions. And these are skills that can and should be part of training for patient advocates. But of course, they require a good deal of management, time and attention focused on making sure that they're developed and maintained. And ultimately, patient advocates are just knowledgeable about all possibilities that exist for patients to get coverage and pay for their medical bills. Knowledgeable of them, but if they don't have an answer, they have a place to go to get that answer. And they can anticipate obstacles that are coming up, and then they know how and are empowered to overcome the obstacles, excuse me, to find the best solutions. And all of this starts just by listening to patient stories. So in addition to some of the soft skill training and development, the continuing education around technical components must also be robust and ongoing as well. Patient advocates need to know, like I said, all the ins and outs of the federal and state programs and availability of ancillary programs like victims of violent crimes. If such a topic surfaces in a patient's story while talking with their advocate, they can put them in touch with those programs and resources, and that can go just a long way to make a patient successful. And if they don't know about the local resources, they can't connect the patients to them. And I know that many of you were probably at the IRHA annual conference, and just in listening to the various presentations and speakers and talking with some of you, there are a lot of very valuable community resources that are available. It's just a matter of knowing where they are and how to connect patients to them. And, as I think about how to describe coverage program requirements and the evolution of them, I think continuous change might be the best way to describe it. Edits to regulations and new regulations and ongoing changes are just literally never ending. I read a figure recently that there were over 8,700 changes last year alone to healthcare programs across the country, including new programs available or changes in eligibility criteria and updated application processes. And the only possible way that an advocate can keep current on all of these changes is to be backed by a team of experts with resources and education from which they can draw to tailor the patient solutions for their patients that they're working on. They're not always going to have every answer, that's for sure. But when they're not alone and backed by experts, they know who to call for answers and can efficiently keep moving forward to the best solutions for their patients. Because these rules are dynamic, and we've seen it especially over the past 18 months. It's been critical for advocates to have current and real-time knowledge of these changes, because some of the nuances that we've seen throughout the pandemic, like electronic signatures or other items like that that were regulations were maybe eased or other things were added to make the process faster and easier, provide real opportunity to get coverage where it might not have been available before, or to get it in place faster for patients, which of course delivers on getting payments to the hospital in a shorter amount of time as well. So access to information, resources, and training and development are really important. In addition to that, though, I'd be remiss if I didn't mention that advocates, and it varies by state, need to have necessary state and federal licensures and certifications constantly up to date and required, that those that are required in order to be able to serve their patients. So now we've talked about why face-to-face interaction is important and the expertise that is needed by patient advocates so that they can be effective. But now let's turn to some of the more essential components and touch points of the enrollment process and how to integrate them into the overall patient experience. Before I do that though, Allie, is there any questions that have come up regarding patient advocates?
Nope, we're still good.
Okay, thank you. So in talking about this enrollment process, there are multiple touch point opportunities to consider including in your process, ultimately with the goal to make sure that no opportunity to secure coverage and get a bill paid is missed. No two patients or families situations are alike, and they all interact at different touch points with varying needs. So having advocates with the ability to engage with patients throughout their journey of care increases coverage opportunities. And that's what we're looking for when thinking about how to place advocates in different touch points. So what does this ideal enrollment process and touch points within it look like? Well, many times we can start even before the patient arrives. And one area in the claim life cycle that's often overlooked in the entire revenue cycle strategy is that pre-registration before the visit even takes place, and what can be done on the front end to prevent the claim from becoming a lot of work and time on the back end further along in the revenue cycle. So when advocates are included in that pre-registration process, eligibility for enrollment can begin even before the patient arrives. And it goes well beyond just verifying current coverage, because I know a lot of pre-reg programs do start there, but it extends out to even include many of the items that we've talked about today. So looking for opportunities to maximize coverage and maximize what services are covered while addressing the needs of the family even before a claim exists is absolutely where listening to a story can begin in the entire enrollment process. We also find that primary care clinics as part of the overall health system are sometimes excluded or just not included at a maximum level within the enrollment process to the extent that they could yield the most value for the hospital. Placing advocates in a clinic or directing patients to where they can meet with an advocate and follow up to a visit is a really good way to be sure not to miss the opportunities for finding coverage for patients who maybe don't end up in the hospital where typically the advocates are situated, but still have an impact on the revenue cycle. Many facilities we know end up writing off claims that honestly could have been paid, and getting these patients coverage early in the claim cycle should be an important part of the overall revenue cycle strategy. I'm going to share a couple of stories with you in a few minutes, but I just wanted to share one quick example of a clinic situation where this was effective, and having an advocate there was really valuable. one of our veteran advocates shared with me a story about a free clinic that was affiliated with a hospital client of our company's that she worked for, and that was providing many services to patients in the community free of charge. It was a free clinic, but the cost was becoming unsustainable for the hospital system. So they asked her if she would spend one morning a week at that clinic and assist the patients with applying for any services that they might qualify for. So after a period of time of her going once a week and working with the patients in that clinic, they started to find that more in that patient population were signed up for healthcare coverage. And, obviously that resulted in a reduction of financial burden that the clinic was placing on the hospital. And that clinic could finally survive on its own and not be a financial drain for the system. And that is just such an awesome example of a really valuable system or valuable service that was being offered to a community through that free clinic that remained viable because they didn't miss opportunities to get patients coverage and ultimately as a system to get paid for the services. Probably one of the most obvious touch points is, of course, the emergency department. And a lot of times this is where registration is located or, generally speaking, sees a lot of traffic in some hospital settings. But the challenge here is to capture every opportunity, even in the off hours. So every emergency department's a little bit different, but creating an enrollment process that allows for some flexing within the advocates' staff so that they can be there when it's most busy for that emergency department. It's just really important. A lot of times that's kind of later in the day, maybe weekends when, typically regularly scheduled staff might not be available. So we talked earlier about the figuratively meeting a patient where they are, but physically there's an opportunity to do the same. And when a patient is in an inpatient unit, a lot of times that's not the the place that comes to top of mind where you'd want to put an advocate to talk to a patient about coverage. But a lot of times this is where the coverage conversation can continue, or in some cases really even begin. It does require another one of the soft skills that we talked about earlier, in that an advocate needs to have the ability to meet in a clinical setting and relate with doctors and nurses and understand how all that works. But working with these patients even after they're admitted provides another layer of opportunity to get them coverage. And oftentimes what we find is that visiting patients in their rooms when it's allowed and it doesn't interfere with the hospital clinical protocols is a really productive way to interact even with family members who might need coverage as well, or those family members who are acting as the liaisons to help provide details and paperwork that the patient needs to provide. Again, just having them, the advocates, have access to the inpatient setting is another, like I said, layer of opportunity to secure coverage and get invoices paid. And you don't want to miss that as you design out your enrollment process. And it's called a process for a reason. That's because it's ongoing. It doesn't stop until all avenues have been explored. So obviously, especially with the rise in outpatient services as part of the patient mix, having an advocate in the outpatient setting is also very important. So that, if there are follow-up appointments or even going into drop-off paperwork, it's just yet another area for an advocate to be present for opportunities. Now, this isn't an exhaustive list of areas of opportunity because every hospital is unique. I don't have a list of all of you that are on the phone today, but I'm sure if I scrolled through it, I could see a lot of different hospitals and even picture some of them that, your circumstances are unique. So there, the moral of the story though, is that you just need to be where the patient is. And that's the best way to capture their attention because it's not just a one and done conversation. One area that's not listed here that I wanted to mention that's often overlooked in this process is the early out environment. A lot of times we think about that as collections or billing or something else, but a lot of times accounts will get to this, early part of the payment process and they still haven't secured coverage, but they're eligible for coverage. So it's another opportunity in working with patients while you're working with them to set up payment plans. You might uncover that they don't have coverage you have that ability then to connect them to an advocate to get that coverage in place. This is also where sometimes retroactive coverage or even expanded services coverage comes into play, which only helps the hospital on reimbursement with the early out accounts, but definitely helps the patient in getting out from under any medical bill stress that they might have as well. So what we're talking about here is truly a population approach. It's not just focusing eligibility and enrollment services on Medicaid or just the patient, but including the entire family and evaluating all of their options, working through the process with them. So you're not stopping at a denial, but staying on top of the applications and following through even to redetermination for many of those clients that are patients that you're working with. Continuous coverage is just so important too. I think, we think about the patient that's here today and getting them covered for the services that are about to be rendered, but that patient might have to be there for a month or come back for follow-up treatment. And while they may be covered today, next month something changes within their life and they've lost coverage. So having someone to focus on that continuity of coverage is really important. And taking this population approach to enrollment, it's more of a long-term, sustainable strategy. Obviously you want to find coverage for current patients, but what if you had enrolled them maybe when they were at your hospital 6 months ago with their spouse? Now when they show up as a patient, they have coverage, and that means that the hospital's efforts to get paid become less involved. You're positively impacting your cost to collect even before a patient becomes a patient. So can't get much more proactive than that. And one client example of ours that I wanted to share with you today is that we have a client who, like that system, had the free clinic and wanted to put an advocate there. This particular client, who actually is in Indiana, sent their advocate to the local community center one evening a week where events like AA were taking place, because they noticed that in their community, this center was a place where many of their patients in their patient population go for programming. And it presented a really perfect opportunity to provide the service of eligibility enrollment for those in their community who needed it. And it was also a great way to support their community and enhance their relationship with them while providing that benefit of covered patients when they would come into the hospital for care. I do see there's something in the chat, Allie. Do we want to take a look at that or just keep moving on?
Well, it's more of a comment than a question. Just one of our participants wanted to share with the other people on the call that the key is making sure that claim aid is welcome in your facility as part of your hospital team. And that's really the best way to have the patient advocate teamed with the proper clinic and corresponding area for success. So if anybody is using or planning to use claim aid, that's just kind of a pro tip from one of our attendees today.
Well, that must be a client or a past client, something of claim aids. And so I appreciate that comment. It's absolutely right. And very good lead into this next slide. So thank you, whoever you were. But the return on investment for on-site advocates happens when there's no missed opportunities. So absolutely integrating them into the process, making sure that they're trained, have access to education and resources that are available, licensed, and also available physically, helps you to capture every opportunity and avoid some of the gaps that might exist in the process to get those people covered. So no missed opportunities, I think, is the moral of the ROI story here. And a basic example of that is, if it's a facility that only has one maybe financial counselor or an advocate that they maybe aren't giving full access to the hospital. Let's just say we'll call her Mary. She's the only person, she only works certain hours, maybe 8 to 5. She gets sick sometimes, or she has kids that get sick, or she might even want to take a vacation with her husband to get away from the kids. But the gaps start to come and appear when who works with the patients when Mary's not there. When she comes back from PTO, her workload is backed up, and that pile of referrals sitting on her desk represents claims that are now starting to hit the system that may not get paid because there's no coverage in place. So, the bigger question too is, what if Mary leaves the hospital and takes all of that knowledge with her? Who fills some of those gaps when she's gone and tries to replace her with somebody else, and we got to start all over again. So yeah, I appreciate that comment. Definitely having somebody there in place strategically, but also having that backup for when somebody is on vacation or sick. It doesn't create a gap and you don't miss the opportunities. Additionally, the thing with having just one person to be the one-man show, sometimes it doesn't allow them to seize all of the opportunities that exist. And particularly what comes to mind is redetermination. So as the status of coverage may change, that's an ongoing conversation. So while Mary might be working with the patients today, and maybe if she's Wonder Woman, she's getting to their family members, but is she going to be able to keep up on all of the changes and redetermination processes that need to take place too? So that's where we start to talk about the retention and the importance of making sure that there's continuity in coverage. So in preparing to talk to you today, and I'm almost wrapping it up here, Phil, because I know you told me to keep it on a certain time schedule, and I think I'm almost there. I did talk with some of our advocates and just wanted to provide some, feedback from them and what they're seeing with some of their patients who are actually coming through the door. One advocate that I talked with her name's Denise, and she's been in the field for 14 years now, and she currently oversees actually all of our training and education and regulation updates for our team. But she did work for a number of years actually as an advocate in a rural hospital. So I asked her, what's the importance of having, both available updated information, and what kind of feedback are you receiving from some of your patients? And I just thought it was really interesting. I don't want to read through all the text on the screen, but some of the things that she told me was that a lot of the patients she's worked with over the years have expressed such relief that they have a real live person that they can talk to, because they say when they call some of the state agencies, they refer to them often as application mills, but they're frustrated that they get auto attendance, or if they just have a quick question, people don't call them back. And she frequently heard how much her patients appreciated that they could call her, and if she wasn't available, they knew that she'd call them back, because she went on to tell me that she believes financial care goes beyond simply filling an application out for somebody and leaving them with more things to have to take care of, because these patients have enough on their plates. And I loved how she positioned this, that patient advocates can smooth the road between the patient and the bureaucracy of state health coverage programs, and that they can be a ready resource for a population that's sorely lacking, which I thought was just an awesome way to position that. But one other thing that she pointed out is that, we talked about all of the different changes and coverage programs that are available, 8,700 different changes throughout the country in 1 year. I mean, that's ridiculous. But what Denise pointed out to me is that many of those updates and nuances and eligibility requirements, they're not available to the public. Those things are kind of buried in underneath different state agencies, and you have to know how to get to that information. So advocates really bring to the table that broader vantage point from which they can find solutions that a lot of times patients wouldn't be able to find for themselves, which again is just going to hang those claims up in that claim life cycle when they really don't need to be hung up. There are solutions to getting them paid. So I just want to wrap up the session today with a little bit of bragging, just for like 1 minute, if I can, Allie, about some of our advocates. This past 18 months was extraordinary. And I've heard so many fantastic stories of how hospitals, like many of you on on this call today. Your employees are getting so creative and solving problems. And we've all seen the, TikTok videos and YouTube videos of just the cool things that some of the clinical staff are doing to solve problems. And like I said from the beginning, we've been doing this for over 30 years, working in hospitals in the Midwest and helping patients find coverage. But man, this last year has provided so many new opportunities to figure out how to do it even better. And I think that speaks to the value of the available and compassionate on-site staff being able to go the extra mile to get patients what they need. And it's a great relationship builder too for the hospital and patient relationships. And such a great contributor to the patient's overall experience. But ClaimAid goes curbside. That was kind of our little tagline because, I'm sure our advocates can tell lots of stories about how they've, overcome barriers to just get access to the patients. But this year, because access to hospitals was so restricted, and rightfully so, it made a lot of patients nervous, especially those that were family members coming to see a sick relative. They didn't necessarily want to come in and go through all of the process. We had one patient's wife who had a husband in a nursing home, and she just didn't feel comfortable coming in to meet with the advocate. So, the advocate went out to her car and just tried to lighten her load and take care of things out there. And we had another advocate that did that like in the dead heat of summer. And as many of you probably also experienced, you go out one door to get to the parking lot. Well, that locks behind you. And now you have to walk 2-3 miles around the hospital, it feels like, to get back in. And we had an advocate that experienced that as he was working with patients out in the parking lot and going back and forth trying to get copies made and signatures and things like that. So he at least looked at it like, I got my steps in for today. But one of my favorite stories that I heard was about this mother who had 5 kids, young kids, and she had a signature that was due, and she just was not going to make it because masking up 5 kids and dragging them into a hospital to, go to the advocate's office just didn't work for her. So she needed a signature the following day, and the advocate said, "Hey, you got baseball practice tonight, just swing by the hospital. I'll meet you out, close to the road, and you just sign this for me. We'll be all set." And lo and behold, it happened, and they went on to get their coverage. So, I just think that there are lots of ways to incorporate this into the process, but, just having the right people to do it, and, being available for the patients so that no missed opportunities fall through any gaps in the enrollment process. And with that, Phil, I will say thank you to everybody who joined on the call today. I'm happy to take questions for the last few minutes, but also my contact information is right here for you. And hopefully I'll see lots of you at the Don Kelso golf outing next Wednesday, put on by IRHA too. So thank you for this opportunity to talk with you today. I really appreciate your time.
Thank you, Traci. Really great information there for everybody on the call. And we appreciate everybody joining us on the call today. I don't have any more questions yet. We'll go ahead and leave the line open for just a minute or two. But again, we have recorded today's presentation, so it will be up on the site, our YouTube channel, by the end of the week. So once again, thank you, everybody. Phil, if you have anything you want to add.
Yes, I just want to thank Traci for making time to do this today. We value the resources that our business partners bring to our members, and ClaimAid has been a business partner with IRHA for several years. They work in the majority of our hospitals. They do a great job of helping our hospitals with their revenue cycle needs. And in Traci's discussion today, she clearly indicates that it's far more than just jamming a form in front of somebody, that it's a matter of developing that relationship, and ClaimAid does a good job of that. So Traci, thanks for your time. Thanks for sharing your information.
Yeah, thanks, Phil. Thanks, Allie.
And thanks for that shameless plug for the Don Kelso Golf Classic.
I can't wait.
Back to you, Allie.
Okay, well, we're going to go ahead and end the session. Everybody has Traci's contact information there. Just hope you all have a great afternoon.